Hello, I am Director Kim Young-jae from Korea Dental Hospital. Today, I will explain about the most straightforward mandibular posterior implant. This patient visited us with multiple tooth loss, along with multiple dental caries. The maxillary prosthetics were completely finished, and this patient came to us after breaking his tooth while chewing food. He underwent cancer treatment, received radiation therapy, and subsequently developed multiple dental caries and had his teeth break. We plan to extract the broken tooth and place 1, 2, 3 implants. I recommended the patient to also consider a second molar implant, but due to cost constraints, we decided to place up to the first molar only. The maxillary implants are being maintained very well. The point to focus on here is that if you place it about 2 millimeters deeper than the crestal bone level, a platform switching phenomenon occurs, causing the bone to grow like this. Even after the procedure, and with the prosthetics in for a patient who received radiation therapy, the bone around the implants is well preserved. The patient's bone volume appears to be sufficient. Since this patient will have an implant placed immediately after extraction, the implant is expected to be positioned well. The patient's bone condition is not very good. Following radiation therapy, the bone is expected to be soft, but drilling as well as fixture placement should proceed without significant difficulty.
울려요. 놀라.
달치아를 기준으로 가볍게 됐습니다. 오케이. 4.7 드리면 되고요. 5.1 넣겠습니다. 철고정 일어날 때까지 잘 됐습니다. 아웃
언니 알보십시오. 위아래로.
콤빌리드를 잘 됐습니다. 임플란트입니다. 플러그 제거하겠습니다. 본 타입을 추천해서 수요일은 잘 알면 한 16톤 되고 20뉴턴 정도 되거든요. 이게 플러그 연결합니다. 요거 5분 뒤로 뒤로 약간 당기겠습니다. 됐습니다. 서브로 들어간 만큼 길이 맞춰 써줍니다. 연결했고요. 넣겠습니다. 인터덴탈 파트야. 이거 수치하시면 더 편하죠. 좋습니다.
Because there is an extraction space, it is a very easy case for implant site preparation. The bone quality is between D2 and D3, and specifically the area of the mandibular right first molar is approximately between D3 and D4. Although the initial drilling started in the interradicular bone, the drilling shifted from a hard to a soft area, and the implant is positioned slightly distally. The position and direction of the fixture placement are good enough not to cause any issues with prosthetic restoration. As mentioned earlier, placing the implant slightly subcrestally from the crestal bone level helps preserve the bone around the implant in the long term, which is a good method to prevent periimplantitis. The procedures were performed at 4.7 by 11 millimeters, 5.2 by 11 millimeters, and 6.7 by 11 millimeters, respectively. In cases where the condition of the bone, particularly the bone quality, is poor, we recommend placing a wide fixture. Using a fixture with a smaller diameter does not provide good initial stability. The initial stability should be calculated per surface area. Therefore, wide fixtures are recommended because they provide sufficient initial stability even in soft bone. During surgery, the implant for the right mandibular first molar slipped while ratcheting. Ratcheting has less vertical pushing force. In this case, initial stability should be achieved by the screw being drawn in as it rotates, but there was no pulling force for this patient as he had D3 bone. So we manually connected the knob and inserted it backwards with hand stabilization. The knob, when used with maximum force, can achieve about 20 Newton centimeters to 30 Newton centimeters. But earlier, it is estimated that it was applied with around 10 Newton centimeters to 15 Newton centimeters of force. If more force is applied beyond that, the bone between the threads can strip away. This could result in the failure to achieve even minimal initial stability. So I chose a wide fixture and placed it using a tactile sensor. Considering the bone quality, we achieved an initial stability of about 10 Newton centimeters to 15 Newton centimeters. Next, we need to consider the periodontal ligament remaining after extraction. There is something called mesenchymal stem cells. Thus, bone regeneration is quite active initially. In such cases, I believe that we should rely on the regenerative power of the bone to achieve osseointegration rather than relying on initial stability. This is a typical case with nothing particularly special. We can confirm that the implant fixture is placed in a good position and direction. The cortical bone is maintained to some extent, but because it is hollow bone, it is difficult to achieve initial stability. However, in the case of the first premolar, there is plenty of hard bone around. There is some in the right second premolar of the mandible as well. If you look at the first molar, it is difficult to achieve initial stability in hollow bone. So when you continue to forcibly rotate insert to achieve the desired amount of initial fixation, fixture dropping can occur. Also, there are many dentists who panic because all the bones between the fixture threads are broken, causing stripping phenomena. Therefore, I think it is correct to use a very precise tactile sensor to obtain minimal initial fixation force. Another point to consider is that, in fact, even a 6.7 millimeters fixture is not quite large enough. Bone housing. I believe that a 6.7 millimeters fixture is small compared to the size of this patient's bone. Therefore, it seems advisable to plan for the placement of 7.0 millimeters or 8.0 millimeters fixtures. It went in a little less than drilling. Cortical bone anchorage was formed on the labial side. Since the bone type is not good, you need to wait more than 3 months. Waiting 4 months is also okay. It is expected that prosthetic restoration for the first and second premolars will be possible within 3 months. I think we should wait at least 5 to 6 months for the first molar.